and introduce Dr. Betsy Wilder, who is the director of the Office of Strategic Coordination, or like Rajiv said, also known as the Common Fund. Dr. Wilder is a strong proponent of including sex as a biological variable in biomedical research. Oops, no problem. And has worked hard to provide support to investigators involved in Common Fund programs who want to include SABV into their studies. So can you please join me in welcoming Dr. Wilder to the podium?
Thank you, Paul, and I just want to thank you and Rajiv so much for putting together what looks to be really an outstandingly interesting workshop. I'm really looking forward to it. So as many of you probably know, but some of you may not, the Common Fund is a trans-NIH source of funding at the NIH that is intended to support transformative programs that are intended to transform either health, knowledge, or the way that biomedical research is conducted. So we support about 30 programs that have those overarching goals. And in pursuit of transformation, we often develop new tools, new technologies, but often also big data sets that are hard to generate without a dedicated source of funds. And what we have often found is that, well, I should say that all of our data sets include data from both sexes, not because specifically to do sex as a biological variable research, but just because it's good science. So what we have often found is that demonstration projects that demonstrate the utility of our data can be really, really helpful in spurring additional use of the data because they demonstrate what the big data sets can be used for, what types of questions can be addressed. So we felt that our Common Fund data sets were just gold mines for sex as a biological variable research. So we were really happy in 2014 to be able to support several supplements to our programs that would allow sex as a biological variable analyses to be conducted. And I'm really excited about hearing about some of that research today. And it has really just been a pleasure working with Janine and talking about this for the past 3 years. So I'm just going to sit back and enjoy.
So I'm privileged and honored to welcome Dr. Janine Austin Clayton, the Director of the Office of Research on Women's Health. Dr. Clayton is a renowned ophthalmologist and has spearheaded SABV on a global perspective. She and Dr. Francis Collins have co-authored a seminal Nature commentary in 2014 where they have outlined the need for a policy on how to balance sex in cell and animal research. Without further ado, I would like to welcome Dr. Clayton to the podium to welcome the guest and open the workshop. Dr. Clayton.
Good morning, everyone. How are you? I like to do that at the beginning of all of my talks because we need to be here together, and there's always things and phones and everything else that we could do, but I just want to say good morning and thank you all for being here. I want to add my thanks to Dr. Wilders for Rajiv Agarwal and Paul Barrett's work. They are really the linchpin of getting this workshop off the ground. So we're here today to talk about sex as a biological variable, and it's delightful to have so many researchers here, both those who normally work at sex differences and those who don't. A central element, of course, of NIH and ORWH's mission is to enhance and expand women's health research. And in today, 2017, that involves looking at sex and gender influences in health and disease to inform and improve the health of women. In pursuit of this goal, ORWH has, as you heard, developed a funding initiative and then spearheaded the new NIH policy on sex as a biological variable, or SABV, and both of those efforts are aimed at counteracting the historical over-reliance on male subjects in biomedical research. The most recent of those initiatives is, of course, the SABV policy. And as researchers, we're taught that a cardinal rule early on is to investigate, not to speculate. So it's something that, as researchers, we have, it's been drummed into our heads from the very beginning. In the past, unfortunately, many members of the biomedical community thought that sex wasn't that important in research, but were they speculating or investigating? Historically, women have been excluded from clinical trials, and data from studies involving only men were applied to women. The emphasis on preclinical research was also biased toward the use of male animals, and this tendency remains in many fields and areas. Today, we see things differently, however. We know that women and men are both the same and different at the same time, and knowing when they are different can make all the difference in the world. As scientists, we can't afford to speculate. We want to investigate objectively and report on what is. That's the essence of data. This is why ORWH is leading, along with my colleagues at NIH, the implementation of this new policy requiring that sex as a biological variable be factored into research designs, analyses, and reporting for studies involving vertebrate animals and humans funded by NIH. Accounting for sex as a biological variable begins with the development of the research question. Excuse me, and then the study design follows the research question and also influences how the data are collected, the results are analyzed and reported. And prior to the development of the policy, ORWH initiated a program to catalyze research into sex and gender influences in health and disease by providing administrative supplements to ongoing NIH-funded research. This Sex and Gender Administrative Supplement Program began back in 2013, so well before the policy, and it has certainly been a huge success ever since. ORWH awards these supplements to enhance preclinical or clinical investigation for research that addresses both preclinical and clinical aims. On average, about 65% of these administrative supplements have been awarded to research that is only preclinical, because that's where the over-reliance on male animals and males is most problematic. ORWH has also awarded 25% of these grants to research that is only clinical, and 10% to research that is both preclinical and clinical. So this research has gone to NIH grantees. You are here, many of you, the cream of the crop in the biomedical research community who can apply for these supplemental funds. Since the program's inception, ORWH has invested over $29 million in these administrative supplements and supported more than 250 investigators with parent grants from most of the NIH ICOs. By design, these awards are meant to be complementary rather than to provide funding for a separate approach. This was a strategic move focused on making the whole more than just the sum of its parts. Providing supplemental awards has motivated brilliant investigators from many scientific disciplines to consider questions that they had never thought about before, namely, what influence might sex or gender have on what I'm studying? Over time, this approach is helping to build a robust body of evidence about male and female biology that will inform prospective research, including studies with sex-based hypotheses. ORWH is really pleased to be hosting this workshop with the NIH Office of Strategic Coordination in the Division of Program Coordination Planning and Strategic Coordination, which manages the Common Fund programs. The director of DPOCPSI, Dr. Jim Anderson, saw that the value of this administrative program, supplement program, for enhancing reproducibility through rigor and transparency, and for contributing to a transformative shift in science by correcting the fundamental sex imbalance in biomedical research. As a result, the Common Fund began magnifying ORWH's efforts by making strategic investments to incorporate sex differences focus into existing Common Fund projects, as you heard from Dr. Wilder. For example, the Common Fund's Visionary GTEx project was launched in September 2010 to examine how human DNA variation correlates with gene expression across multiple tissues. They, of course, included both males and females, Although they were not planning to look at sex differences, this was just about doing good science. Samples were collected from several hundred male and female donors for dedicated analysis. Accordingly, the Common Fund has granted supplemental funding to a number of GTEx researchers to motivate critical comparisons between the sexes using this incredibly valuable data set. Today and tomorrow, we'll hear from researchers at the forefront of their fields who have received the supplemental funding from ORWH or OSC for their research on sex differences in brain function and behavior, sex effects, and their interactions with key external factors, sex in animal models, and sex in gene expression. Like ripples on a pond, ORWH's Sex and Gender Administrative Supplement Program and the similar supplementary funding provided by the Common Fund are invigorating research into the pervasive influences of sex and gender on health and disease across the diverse areas of interests of the NIH Institutes, centers, and offices. Together with the new NIH policy requiring the consideration of SABV, these ripples are beginning to have a transformative effect on the way biomedical research is being done. As the positive effects of the policy and these funding initiatives propagate into the community of extramural activities and stakeholders, the outcome will be better health for everyone, regardless of sex and gender. With that, I'd like to welcome everyone to the SABV workshop. I'm really looking forward to all of the great talks we're going to hear today, and it's really a special privilege for me to be able to start this workshop and to introduce our dynamic keynote speaker. You know what they say when you're trying to find a present for someone and that person has everything. What do you get for a person that has everything? Well, in this case, it would be, how do you introduce a person who has done everything? It's my pleasure and honor to introduce Dr. Virginia Miller. Dr. Miller is a professor of physiology as well as a professor of surgery at the Mayo Clinic in Rochester, Minnesota. She's not only a PhD in physiology from University of Missouri, but also an MBA from the University of Minnesota. She is the principal investigator of the Mayo Clinic's Birch program, as well as the SCORE, Specialized Centers of Research on Sex Differences at Mayo. Dr. Miller's laboratory focuses on conditions specific to women: ovarian function, preeclampsia, and menopause. These conditions are associated with dramatic changes in one of the sex steroids, estrogen, which can accelerate the development of many chronic conditions, including cardiovascular disease and in the aging process. Her work evaluates how estrogen affects progression of atherosclerosis and changes in brain structure and cognition in menopause. She has authored over 200 original publications and reviews, and she has worked on numerous grant review panels and editorial boards for scientific journals. Please join me in welcoming Dr. Virginia Miller.
Well, thank you, Janine, for that wonderful introduction. The pressure's on, right? I'm just delighted to be here, and it really is an honor for me to open up this program today, which is the first one on Sex as a Biological Variable conference. So it's a great honor for me to open this program. And I will say that I wouldn't be here without the wonderful support from the SCORE, Specialized Center for Research on Sex Differences, and hope that this program can continue into the future, because it is really making a national impact in terms of how we do our research. So what am I going to do here in my few minutes I have with you? My objectives for this program right now are really to articulate the rationale for developing a sex-based research agenda. I understand that some of you are involved in sex differences research, but others may not be. I'd also like to list at least 3 conditions, have you be able to list 3 conditions of how sex and hormones influence cardiovascular outcomes, describe how vascular function affects cognition, and finally identify, and this is going to be woven throughout my presentation, really identify opportunities for new research. There's no sense in just telling you what we've done without saying what we need to do and how this impacts how we operate. So let's start by articulating the rationale for developing a sex-based research agenda. Why do you think we need a sex-developed research agenda? Well, NIH tells us to. Now, you may laugh and say, really, Virginia? But honestly, I have used this as impetus to encourage investigators to consider it. Because although scientists are very smart, they're also very stubborn, and they're very ingrained in doing things the way it's always been done. So without a little push from their funding agency, it may not happen. But you all here go beyond that, because you're here because you want to learn and you want to broaden your horizons. So really, why do we need to develop a sex-based research agenda? Here is the scientific rationale. Research is the driver for education, and without education, we can't have a cutting-edge clinical practice. A sex-based approach to research is the essence of a holistic approach to patient-centered or individualized health care. And what is NIH about? It's about improving the health of the nation. So this is a must. So let's go back to what are the basics of sex differences. And I use this slide from my colleague Art Arnold all the time because it is like the essence and brilliant to bring everybody on the same page very quickly. Sex differences begin with the sex chromosomes. These are the non-gonadal effects which are present in every cell from conception on. These genetic differences drive the development of the gonads, which result in the production of sex hormones, which affect the organization of things like the brain, the development of the sex organs. But there's also activational effects, which are there when the hormones are present and absent when the hormones are removed. So what hormones are we talking about? We're talking about the development of estrogen and testosterone from cholesterol, which change across the lifespan. So when we think about sex differences, we can't just tune in to one age and think we have all the answers. We have to consider age by sex, by hormones, and by ethnicity. These hormones decrease in both men and women as they age, and of course there's an imbalance in the concentrations of testosterone and estrogen between the sexes. So our investigation of sex differences, it's okay to say that there is a difference, but if you want to understand why, you really need to delve into the effects of these hormones on cellular function, which may change depending upon the age of the material in which you are investigating. So why does sex matter? It matters because there are sex-specific chromosomes and hormones, and because of this, there are sex differences in diseases. And I would challenge you to come up with one condition that does not show some sex difference in either prevalence, incidence, morbidity, mortality, presentation of symptoms, or response to treatment. So you simply cannot ignore it. So what am I going to talk to you about today? I'm going to talk about sex-specific hormonal changes across the lifespan as they affect women. And the disease risks that I'm going to be talking about are those associated with pregnancy complications, surgically induced menopause, oophorectomy, which is actually the human equivalent to what many of us have done, study hormones affect in animals for years, and then the effects of natural menopause with hormone treatments. The general concept that we'll be framing my presentation in today is that, let's see, maybe use this. Does this work? Yeah. Is that the general concept is that the ovarian function and things that are driven by sex-specific pregnancies, the hormonal shifts that result from these conditions to menopause are associated with metabolic changes, which may result in changes of cells within the blood vessel, which affect blood flow. And I have here to the brain. This was our major focus of our score. But I think that this can also be extended to the heart and the kidneys, which we are investigating in ancillary studies. And if you're affecting blood flow to the brain, you're going to affect the structure of the brain, which is going to be manifested in changes in cognition. So let's start first with pregnancy complications. And the pregnancy complication that we were interested in is preeclampsia. And to do this, we leveraged another NIH-funded project, the Rochester Epidemiological Project, to identify women who reside within Olmsted County who delivered their babies between 1976 and 1982. This means that when we bring them back to study, they're now in their 60s or 35 years after their initial pregnancy. And because we were interested in the mechanisms that may be associated with a preeclampsia, independent of comorbid conditions as they may have accumulated as these women age, we excluded women that had frank cardiovascular events, any cancer except skin cancer, and autoimmune disease or neurological conditions. We identified 40 women who had hypertensive pregnancy disorders, and not by code. Diagnostic codes we found to be completely inaccurate in identifying preeclampsia because of the way that blood pressures are measured. So our investigators actually went through over 2,000 medical records to identify these women. So they're very asymptomatic when we brought them in, and we aged and parity matched them to women who had normotensive pregnancies during the same time frame. We imaged cardiovascular parameters, we imaged their brain, and tested cognition. What did we find? Well, let's look at our cohorts first. Our cohorts that had preeclampsia and normotensive pregnancy, and you can see, based on our general concept, that they already differed, even though they were asymptomatic in several important ways. First of all, in terms of their metabolic parameters, they were heavier, they had more hypertension, and they were insulin resistant, and they had a higher inflammatory markers. So they're metabolically a little bit different than the women that had normotensive pregnancy. And how might this impact the cardiovascular measures on top of the fact that they were preeclamptic? First of all, we imaged their coronary arteries. And I'm not sure how many of you are familiar with looking at this. So this is a computed tomography slice through the chest. And if you're trying to orient yourself, the legs of this person are coming out at you. So this is the left coronary artery, and you can see that big white spot there. That's a hunk of calcium sitting in the coronary artery. Not a good thing, right? So when we examined these women, and these were asymptomatic, remember, for cardiovascular events, we found that the women who had hypertensive pregnancies had significantly more coronary calcification than women who had normotensive pregnancies. And you can see, even though this is statistically significant, there is this, the women do segregate into two different groups, some who have no calcium in their coronary arteries. So a question that comes up right away is, what's different about these two groups of women? And this remains to be sorted out as to what might put these women on a trajectory for advanced coronary calcification compared to these. But we didn't just stop with the coronary arteries. We looked at the carotid arteries, and we measured the carotid intimal medial thickness, which is just this layer right here. Here's the carotid artery, the lumen of it. And indeed, the women who had preeclamptic pregnancies also had a greater thickness of their carotid artery. So we've looked at two vascular beds and found accelerated cardiovascular disease in women that had preeclamptic pregnancies. What about the cerebral blood flow? Well, we measured the blood flow through the middle cerebral artery by ultrasound at the side of the head with, in response to breathing carbon dioxide. So this was a stepped change in breathing carbon dioxide, which should result in a dilation of the vessels to increase the blood flow. Here's the middle cerebral artery blood flow. This is end stage, end tidal volume CO2. And if you plot this, you get a slope, and this slope is the measure of cerebral vascular reactivity. So the higher the slope, the better that these cerebral arteries are responding to this hypercapnic stimulus. And when we look at these this response, we can see that the increases, or the cerebral vascular, the blood flow in the women that had normotensive pregnancies was significantly greater than the women that had preeclampsia. And with the calculated slope of these, you can see there's a significant reduction in cerebral vascular reactivity in women that had preeclampsia. So we've now moved from the heart to the coronary arteries to the brain. So what happens in the brain with these changes in middle cerebral artery blood flow? So this is an image of the brain. This top one is the brain cut in half. This is the back part of the brain, the occipital cortex. And what we have here is the red zones represent areas of the brain which are atrophied in women that have had preeclamptic pregnancies with current hypertension compared to women who had preeclamptic pregnancies with no hypertension. And you can see that the hypertension in these women after the pregnancy significantly affects this area of the brain. Well, is brain function affected by this? Remember, these women are 60. And, I mean, 60's, I'll say, is young. Okay? And when you do cognitive testing on women in their 60s, you're not expecting to see a lot of change. And indeed, the battery of tests that we performed on these women, which were 10 to fix all the areas of cognitive domains and so on, there weren't significant difference in the overall scores. However, if you do a clinical assessment which uses a different criteria for defining cognitive function on these women, what you find that the clinical consensus diagnosis of the cognitive status in these women affected multiple domains, and that there was indeed cognitive impairment in the visual spatial function, which you would expect with the changes in the occipital area. I love it when data follow what you would think, what you expect, because it's physiologically relevant and reasonable, right? So I think these are very important findings. And it also tells us, I think, that when we do cognitive testing on people, when we look at the Z-scores for these tests and what the ranges are, that they're pretty insensitive in terms of what is really going on in performance. And we're really liking this idea of using a clinical consensus diagnosis because it uses a different measure of comparing the results of these tests. And I just want to raise that as an important consideration for some of you who do these kinds of things. Well, my general concept, I presented the idea that we were looking at how perhaps activation of the cells within the blood vessel would contribute to some of these vascular changes. And so I just want to remind you that within the blood there are many cell types that don't act independently. They interact, they bump into each other, and if they're activated, they release bleebs of membrane that contain vasoactive substances, and their interaction with the vascular wall can result in activation of the endothelium and development of a vascular lesion. These bleebs of membrane are called microvesicles, and the biological material that they contain, once they attach to another cell, can be transferred to that cell, and that these microvesicles do contain proteins, surface proteins, that are particular to the cell by which they originate. And if they express certain factors, are also prothrombogenic and promote blood clots, when you can get microvascular damage, reduce blood flow, and of course end organ damage. How did we evaluate an activated vascular compartment? Well, I don't expect you to read all this, but we measured 38 parameters within the blood. We measured total blood cell count. We looked at a variety of platelet characteristics. We looked at the blood-borne microvesicles from multiple cell types. And then we looked at the interaction among the cellular elements. And we can do this by dual-labeled flow cytometry, where the cells can be labeled with a marker not only for the parent cell, for example, for platelets, but also for the cell that they might interact with or contain, grab onto a microvesicle, for example, here a leukocyte. To analyze these data, we used the principal components analysis, and here's what we found in a nutshell. So when we looked at the relationship between the activated vascular compartment and coronary artery calcification, we found that there was an association with procoagulant microvesicles, microvesicles expressing cell adhesion molecules, and microvesicles derived from leukocytes, endothelium, senescent cells, and adipocytes. These cells are consistent with the theory that calcification results from senescence of cells within the vascular wall, the infiltration of monocytes and accumulation of fat, and the calcification of those tissues. When we looked at the association with carotid intimomedial thickness, we found that it was related to the number of blood elements, but here we found more of a prominence of the platelet aggregation and the platelets interacting with monocytes and granulocytes. The difference between these is consistent with the stage of vascular disease in each of those vessels. This has calcification. The carotid intimomedial thickness was just barely beginning to develop a different cellular process in this vascular bed. When we looked at cerebral vascular reactivity, we found that it was associated with the number of platelets and platelet activation and the monocyte endothelium interaction. Again, this makes sense. If you're breathing a CO2 stimulus, that's going to activate those blood cell elements. The platelets, they're the 911 responders in the vasculature. They're going to be releasing their guts right away. What do platelets release? They release vasoactive substances, most of which are vasoconstrictors. So this makes perfect physiological sense to me, and also identifies that when you're talking about looking for biomarkers of vascular disease, you really have to think about the interaction of the cells within the blood compartment and what particular end product you're trying to measure, your endpoint. There's going to be different markers depending on that endpoint. So what have we found from our preeclamptic pregnancy data? Summarizing, we found that there was indeed increases in metabolic changes. We had increased intravascular cellular activation, which resulted in increases in coronary calcification, carotid intimomedial thickness, decreases in cerebral vascular reactivity, increases in brain atrophy, and decreases in some areas of cognition. So what are the opportunities here? We are pushing for a change in the monitoring of women following hypertensive pregnancies. Here is a wonderful opportunity for women who have had a hypertensive pregnancy to be monitored more regularly before they reach menopause to reduce their chance for reduce the presence of ongoing hypertension. We want to be able. I want to go back. We want to be able to include a pregnancy history in assessing chronic disease and long-term care. Many of you, when you women go into the doctor's office, how many of you have filled out a form and you have to put in your age of menarche, number of pregnancies, number of live births? Is there a question there if you had pregnancy complications? Shake your heads, ladies. No. We need to change clinical practice in this regard, and we're trying to develop a clinometric tool and validate it to do that. And then, of course, there's really an opportunity to investigate the underlying genetic and hormonal changes that contribute to preeclampsia and really separate out those women who may have pre-existing genetic predispositions to preeclampsia that is exposed by the pregnancy compared to women who develop the preeclampsia for some other reason. So let's move to surgically induced menopause or oophorectomy. Again, this is a clinical practice. It's recommended for women who not recommended, but it is performed in women who are at high risk for ovarian cancer if they're BRCA positive. But it's also performed in women who have benign disease or no disease at all. Is this a good clinical practice? Well, what do we do in experimental animals? I worked in those for a long time. If we want to study the effects of hormones, what do? We whip out their ovaries, right? Here's a human equivalent to it, and it's actually being done in clinical practice. What are the consequences? Again, we turned to the Mayo Clinic study of aging using the Rochester Epidemiological Project with one of my coworkers, Walter Roca, who heads up that project. And what he did and his colleagues was evaluate women who had their ovaries out between this age time period. And I want to focus specifically on the women who had their ovaries out before the age of 45, which would be considered sort of early menopause, because the natural age of menopause in American women is about 52. So we had over 1,000 women that had their ovaries out before the age of 45 with referent women, which are women who did not have their ovaries out that were the same age. And then they looked at the 14-year follow-up and evaluated, based on the Department of Health and Human Services, what they consider chronic conditions of aging or multimorbidities, and these are those that are represented here. So it's a cumulative record of these events. And because the Rochester Epidemiology Project is linked to the medical record, we are able to accurately identify these conditions apart from code. So what did Walter Roca and his colleagues find? The average index age of the oophorectomy was 41. And what I'm going to show you here is just one piece of data, which are those women who had no conditions at baseline. So you always have to wonder, if you look at some of these survival curves and also the number of accumulation, multimorbidities, was there something about the women that they had ahead of time that was accelerated by the process? So by eliminating women who had any of these comorbidities ahead of time, we were able to really see the effect of oophorectomy. And what did he find? He found that within 6 years, there was an accelerated accumulation of the number of comorbidities of these women. After about 6 years, it begins to parallel what you would see with the normal aging process. But this acceleration here, within those 6 years of having the procedure, is dramatic. 18 conditions. And this was statistically significant in terms of the hazard ratio. Well, let's just pick one condition and see what that means in practicality. So one condition we looked at was cardiovascular mortality. And indeed, women who had their ovaries out before the age of 45 had increased cardiovascular mortality. So let's see, risk of ovarian cancer is what percent? Less than 1%. Risk of dying of cardiovascular disease for women, 1 out of 4. Think about it. What happens if we treat these women, however, with estrogen? Here's the referent population in terms of survival. Here are the women that had their ovaries out before the age of 45 and were treated with estrogen, and those who did not. The survival curves are statistically different. Clinical practice now requires women who have their ovaries out before the age of 45 to be treated with estrogen. Of course, the question remains is how long this treatment should go on, and that's still under debate. But we are in the position of promoting the change in clinical practice in regard to recommendations of oophorectomy for women, and also in regard to their hormone replacement. So the summary of what we have learned so far from this cohort is that there is, with a premature loss of estrogen, and I'm going to say other ovarian hormones here too, because the ovaries produce a lot of other things besides estrogen, and we don't know what those consequences might be. There's accelerated aging and increased morbidity and mortality. Now, to sort this out in terms of particular organs, we think that estrogen blocks this process, but the effects of estrogen on some of these multimorbidities may be different, may be tissue-specific, and we need to find out the non-genetic factors which influence this, as well as genetic variants which might be involved in this process. And we'll be talking a little bit about this when we look at our women who undergo natural menopause, which is a segue into my next presentation. We know that there's estrogen effects with the oophorectomy. Are there estrogen effects with natural menopause? And for this, we turned our attention to the Kronos Early Estrogen Prevention Study, which was a privately funded study from a foundation. Was multi-center, 9 centers across the country. The women were screened for pre-existing cardiovascular disease, including coronary calcification scores less than 50. And the women were enrolled between 42 and 58. The average age was 52, right there at natural menopause. For many women, they had to be within 3 years of their last menses. And here are their clinical characteristics. This is about as clean of a group that you can get in terms of a healthy population. And the smoking rate within this group also was quite low, very different from the WHI, the Women's Health Initiative. The women were randomized either to placebo, conjugated equine estrogen, which is an oral formulation, or 17-beta estradiol patch. which will be abbreviated by these two, CEE and E2 going forward. These active treatments, because the women had their uterus, we gave them oral prometrium, progesterone, pulsed for 12 days per month. Again, very different from the Women's Health Initiative. This is a natural progesterone, not a synthetic one, not continuous, but pulsed. What did we measure? Well, the primary outcomes for KEEPS was carotid and total-medial thickness, but we measured a lot of other things too, but I'm just going to focus on this today. And in the cohort that we recruited at Mayo, which was 118 people, we were able to retain 110. Throughout the 4 years of the study, we looked at vascular activation, brain imaging, and genotyping. So what did we find? Well, let's look at the main outcome first. Again, we're looking at this thickness of the coronary carotid artery. And as you can see, much to the disappointment of our investigators, there was no difference between the two groups. Now, let's think about this for a minute, okay? One, we have to think these were very healthy women, okay? It was only 4 years, okay? And how much change would we expect in 4 years with this group of healthy women? So the good thing about this was that there were no adverse effects of these treatments for menopause in these women. And we did see positive changes in their bone mineral density and symptoms associated with menopause. For example, sleep disturbances were reduced. Hot flashes were reduced. Night sweats were reduced. Sexual function was improved. So the treatments were great for these women in this 4 years without a lot of adverse effects, which really should start to change clinical practice again from the fear of using menopausal hormone treatments for some of these bothersome conditions associated with menopause. But let's get back to our general concept, which is looking at the vascular activation. And because we didn't see any differences among the groups, we grouped the data here. And again, we did see some activation of leukocytes and the microvesicles associated with endothelial cells, which express this vascular adhesion molecule, vascular cell adhesion molecule marker. With the development of CIMMYT. Again, consistent with the idea that the leukocytes are interacting with the vascular wall to promote the lesion formation. Well, what about the brain? Okay, this is a different image of the brain. This is cutting across the top, looking down. Here is the cerebral matter. These spaces in here are the ventricles. And what's shown here in green are what we call white matter hyperintensities, or areas of the brain which are developing some dysfunction associated with the myelin connections. What was surprising to us that all the women that we imaged at the age of 52 had white matter hyperintensities, and they all increased over the course of these 4 years. And here are the cumulative data looking at the progression over the 4 years of treatment. Well, these could be, are these associated with any way for the cellular activation that we talked about? And indeed, Limor Raz, who was one of our Birch scholars, evaluated the markers of cellular activation with development of white matter hyperintensities and found that they were associated with the fibrinogen expression on platelets when women came into the study. So women who had activated platelets were more likely to show white matter hyperintensity. And also platelet-derived microvesicles, activated platelets, again, this is consistent with what we saw with the hypertensive pregnancy disorders in terms of the platelets being a major player in terms of what's going on with the cerebral circulation and subsequently in the brain. We looked at arterial stiffness, aortic stiffness, which is a precursor to hypertension and may even show some vascular changes before the peripheral arterial blood pressure measured from the forearm. And what we found with Jill Barnes, who was also one of our Birch scholars who went on to a successful K99, that there was an increase in the white matter hyperintensities with aortic systolic blood pressure. Take a look at these systolic blood pressures here. What do you see about that? Does that look hypertensive to you? This is in the range of what you would consider a normal blood pressure, and these ones up here in 130 is pre-hypertension. So we really need to understand more about the association of what's going on with the vascular changes in the large arteries as well as the small arteries and the effects of the interaction with these blood pressures in this normative range. So you can imagine if the blood pressure goes up, what we might find. And we don't have aortic stiffness on our, unfortunately, on our preeclamptic women. So with menopause so far, what have we discovered? We've discovered that these hormonal shifts affect intravascular activation, and they affect damage to the brain. So there's some missing pieces in here which we have data on, which we're ongoing, and the analysis is yet to be completed, but we expect those data to be done within the next 9 months. So there's much to do. But I'd like to tell you something else we discovered along the way, and that is how the genetics modulate the response to menopausal hormone treatment. And this is an area called pharmacogenomics. Have any of you heard this term before? Do you know what it means? Okay, some of you do. So I see Peg shaking yes. I see somebody right behind you shaking no. Well, let's bring everybody up to the same page, okay? We know Peg is very smart, and you'll hear that. She's a pharmacologist. Okay, that's why. And you'll hear about her work in a few minutes. Okay, so, and I had to learn this from my genetic colleagues, and that's the beauty of some of these interdisciplinary projects, is you learn things. I never thought I'd be giving data on pharmacogenomics, right? I don't, maybe when I was in graduate school we didn't even know about genes, but we did, but barely, okay? So what is a pharmacogenomic effect? A pharmacogenomic effect is a genetic variant, or a SNP, influences the effect of the treatment on the outcome. So the treatment that we're going to be talking about here is menopausal hormone treatments that I mentioned before, which was the oral conjugated equine estrogen and the patch. The outcome that I'm going to be talking about is beta amyloid, which is a protein that's involved in the development of plaque in the brain. And we image the beta amyloid by PET imaging. And here is a normal brain, again, cutting across, looking down. Here is a brain that has high amyloid. And what you need to keep in mind that this beta amyloid pathology develops decades before cognitive decline. It's associated with Alzheimer's disease. There's a genetic variant which predisposes deposition of the amyloid, and the risk for the amyloid deposition and the prevalence of this variant is higher in women than men. The mean allele frequency of this is of this particular allele, or this variant, is about 28%. So that means a fourth of us are carrying it, which is pretty high. So what did we find? In the Mayo cohort of the women we called back, and this is 3 years after they finished the study, so now they're in their 60s, we found that there was a significant decrease in the amyloid deposition of the brain in women that were on the patch compared to what was on the placebo. These are small numbers. It's a small amount of amyloid. This is compared to the placebo group, so that's our reference at 1. But the dramatic finding was that the women that had the allele for ApoE carriers, this decrease in amyloid deposition was greater than in the carriers that were using oral conjugated equine estrogen. And you can see that relationship right here. This is dramatic because what this tells us, and it helps us begin to explain, that when the Women's Health Initiative, which used the conjugated equine estrogen, and there was problems with cognition later on, it really may reflect this genetic variant and the response to treatment based on the variation in the population. And if we look at the non-carriers, we see that there's a slight tendency, not significant, for the conjugated equine estrogen to be improved, but not so much for the patch. So here we have a big pharmacogenomic effect in terms of beta amyloid deposition in the brain relative to beta amyloid. Another genetic variant we found was with, this was with my colleague Ann Moyer, was in SALT1A1. This is an enzyme which sulfonates estrogen, And this is a multiple gene variant because you can have multiple copies of this particular variant. You can have one copy or 2 or 3 or 4, so you really can have a dose effect of the variant. And what we found in the women with KEEPs is that this one particular variant, that the number of copies was significantly associated with the age of menopause. Okay, so if you have multiple copies of a gene, a variant that is involved in sulfonating estrogen, that means taking it out of the circulation either for storage or elimination, it doesn't matter if those receptors are there, you're going to have less active ligand within the circulation. And how this plays out with other types of menopausal hormone therapy remains to be seen. But we're excited about this because we have the opportunity to develop individualized menopausal hormone treatments, perhaps based on genotype, and we're looking at other genotypes associated with estrogen metabolism. We do need longitudinal studies on the types of menopausal hormone treatment, on vascular activation and brain structure, and expand the longitudinal associations with the use of menopausal hormone treatment. And I'm happy to report that we just got funded to be able to do these last two things with the whole KEEPS cohort. We're calling everybody back from all 9 centers to do their PET imaging and look at these responses relative to ApoE genotype and amyloid in the brains. And we're very excited about that, and perhaps in 5 years you'll hear the results of that study. So going back to the initial premise of my talk was, why do we need sex-based research? And I think you can probably all answer that. But let me just remind you. We need to transform how we obtain and apply the evidence. That includes identifying the sex of the cells, of which we do our basic preclinical work in. We have to identify the sex of the animals and include female animals. You all know this. Some of you are shaking your heads. We need to disaggregate data from male and female human participants. Get rid of that word subject, right? That implies that people are not there because they want to be there. It's an old-fashioned term. It carries bad connotation. Let's start calling, and NIH start changing the forms to call them human participants rather than human subject table, which we all have to fill out in our grants. Everybody hear that from NIH? Okay, I'm pushing for that. And we need more women in clinical trials. And some of you can advocate for that by going into your communities and really telling women what clinical trials are about, encouraging your physicians who are running these trials and their study coordinators to ask their patients when they're in the office. Some of these trials, like the hormone trial, it was approved drugs, non-invasive testing, doesn't require overnight stays, and individuals can find out other things about their health that actually they may not find because these tests are very expensive. If we do all these things, we will achieve the NIH mission, right? Which is truly to individualize and have an evidence-based practice that improves the health of the nation, of both men and women. So sex differences is at the core of understanding health and disease. We have to account for genetic variants and the hormones which change across the lifespan and these sex-specific conditions, and that really account for the variability that we might see in response among individuals. It affects the prevention strategies we propose, the symptoms that may express, and the diagnosis, and ultimately the effectiveness of the treatments. None of this would have been possible without this wonderful group of investigators I have from our SCORE, which we've identified here. Some of our trainees, Tracy Weisgerber is here, Jill Barnes, Renee Harvey, as well as our tremendous study coordinator, our original study coordinator, Teresa Zeiss, unfortunately passed away from a female-specific cancer related, or prominent cancer, large cell lung carcinoma. And Kim Jensen stepped in and has been wonderful in carrying that on. I can't emphasize enough how critical it is to have a study coordinator who is passionate about the study and can really relate to the participants that we're trying to engage. So thank you very much. I'm over time, so I don't know if we have time for questions. A few minutes for questions. Okay. Judy.
Virginia, that was an absolutely wonderful talk. I wanted to ask you your thoughts on the role of the timing hypothesis in your findings and the pharmacogenomic findings in particular.
Yeah, fine. That's an excellent question. The timing hypothesis relates to the fact that if you give hormones early, once you start to lose them, it's beneficial. If you wait until many years later and diseases come into play, it's more difficult for the hormones to sort of reverse the changes or slow the process. And clearly for the women who have their ovaries out, and for early menopausal women, we think that early is better than late for a variety of tissues, and that's also pretty much supported by the work from Howard Hodis with the ELITE trial, early versus late hormone treatment, which he specifically designed the study to look at women that were early in menopause, 15 years after, like the WHI, and it was the women that were early on that seemed. Now, there's still a question out there in terms of how long treatment should go on, and the data from what we're seeing, we really think that the dosing is important. So, usually clinical practice from my colleagues that treat these women say, they'll start with something, one dose, and it may not work. And women may come back 4 or 5 times before they even get it figured out. Well, if we knew for sure that some of these women had, multiple copies of SALT1A1, and we're now looking at a transporter as well, and some other genes relative to the pathway, we may be able to develop a quick genetic test to better formulate their dosing and understand how that affects these other processes. Because indeed, these women that had early menopause and we're giving them these low doses, no wonder we had large variability in responses over the 4 years. None of these women weren't being dosed to effect, essentially. And that effect may be different depending on which your primary target for treatment might be. Good question. Mm-hmm.
Yeah, my name is Yoel Sadowski. I'm from McGee Women's Research Institute in Pittsburgh. Thank you very much for the interesting talk. I want to ask you about the first part of your talk on preeclampsia and outcomes. It was a very good, you made some very good points, but obviously sex was not a biological variable in your discussion because men don't get pregnant usually.
Yeah, that's right.
So, but there is sex as a biological component that you did not talk about, which is related to the cause of preeclampsia. Most causes of preeclampsia, as far as we know, are related to the placenta. The placenta is a fetal tissue, and there could be a male or female fetus. Have you looked at the role of the sex of the fetus in the outcomes that you looked at?
Yeah, very good points. The answer is yes. We did look at whether the babies were male or female, and we did not see any differences between the groups. We are trying to take a new look at the causes of preeclampsia. Okay, we think that there may be a predisposition in some of the women to have a thrombotic condition. So we've done some genotyping on these women and have discovered two or three other genes that are associated with a thrombosis. And so we're trying to expand that analysis to see how many of these women within the preeclamptic cohort had that, because we're thinking about preeclampsia as there's a group of women that have a pre-existing condition and perhaps this predisposition to clots related to hormones that may be throwing microthrombi that initiates the response of the baby. Alternatively, there may be another group of women who do not have that, but it may have another condition that may be related to perhaps some other immunological response or placentation that initiates it on the baby to the mom. So I think that there are those two conditions or possibilities out there. That's in the literature, but we really need more work to sort sort that out. So good question, and the idea of the sex of the baby, and of course this is 40 and 40, right? A problem with funding sometimes when you do all these tests, you want to have, try to get this published, and the reviewers come back, you have small numbers, what the heck does it mean? Well, we don't have enough money to image 100 people. And these are clean. I can't emphasize enough how important it is to define the phenotype of your groups. And I think the cleaner some of these phenotypes are for small studies really helps you to get into more of understanding the mechanism. If you have a dirty population and the variability is so big, it's harder to figure out what really the mechanisms might be. I really did go over, I'm sorry. Okay.